Good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our experts. This evening, you'll meet Jefferson's Electrophysiology department who will answer your questions about atrial fibrillation, pacemakers, heart health, and much more. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Hans Stabenow, Electrophysiology Cardiology, and Dr. Adam Gus with Electrophysiology Cardiology. So thank you both so much for joining us. I will just give each of you a minute or two to say hello, provide a little background information about yourself, and then we can dive into the questions. So Dr. Stabenow, let's go ahead and start with you. How are you doing this evening?
I'm doing well, thanks. Hello, my name is Dr. Stabenow. I'm one of the electrophysiologists, which is a cardiologist specializing in heart rhythm problems at Thomas Jefferson University Hospital. I'm happy and excited to answer your questions. I'm one of the newer additions to the team. I've been at Jefferson for about 6 months, and it's been a really great experience so far.
Wonderful. Well, welcome. Okay. And Dr. Gus, how are you doing this evening?
Doing great, Sarah. Thanks for having me today. My name is Dr. Gus. I'm a cardiac electrophysiologist here at the Torresdale Hospital and Abington Hospital in the Bucks County area. I've been with Jefferson now coming up to 2 years. Happy to be here tonight.
Okay, great. Well, thank you both for joining us. And I know that we received a ton of questions, so I'm sure it's going to be quite an engaging discussion tonight. So without further ado, let's get into it. Our first question of the evening, Dr. Stabenow, I will start with you. First question, can you live your life with AFib?
I mean, the answer is absolutely yes, if that's what you choose to do. The only therapy for AFib that we strongly recommend is to take a medicine to prevent the risk of stroke in AFib. As we get older, that risk becomes more prominent, so that recommendation becomes stronger. I would divide the treatment of AFib up into 2 categories. One is to reduce the risk of stroke. That's the blood thinner or the Watchman if needed, if there's a problem with it. And then there's the ablation procedure, which is there to reduce the symptoms of atrial fibrillation.
Okay, thank you so much. All right, Dr. Gus, turning to you now. If someone has AFib, should they get a pacemaker?
That's a great question. It's somewhat limited based on not everyone with AFib needs a pacemaker, but as AFib progresses in some patients, their heart rates tend to get slower over time. And that can require the implantation of a pacemaker as it can help set a minimum heart rate. Or for patients who have very advanced AFib, sometimes a pacemaker is needed to take over the heart rhythm and allow a reduction in medication needs to maintain a steady heart rate.
Okay, perfect. Thank you. All right, Dr. Stabenow, we will go back to you now. Could pulse field ablation help someone who has had AFib for many years? And can you discuss beta blockers for partial relief?
Absolutely. So the treatments you mentioned, ablation and beta blockers, they're both there to reduce the symptoms of atrial fibrillation, which, as we mentioned, is sort of one side of the treatment of AFib. The beta blockers don't do anything to get rid of the atrial fibrillation. They make it so the heart rate is not too fast, which can be important in helping you feel well. The pulse field ablation can absolutely help somebody who has been in AFib for a long time. While it's true that the success rate of the ablation is lower the longer you've been in atrial fibrillation, I have had many patients who have had AFib for a very long time, and with the ablation, we're able to reduce or even eliminate the AFib for many years. And so I think that, if you think that you have symptoms from atrial fibrillation, an ablation is absolutely something to consider, even if it's been going on for a long time.
Okay. All right. Thank you. Okay. Next question here, Dr. Gus. Does AFib in the elder population, so 70, 80 years plus, occur more frequently than among younger individuals? Can you talk to us about that?
Sure. So AFib can occur at almost any age. It is a little less likely as when we're younger, and sometimes people who are younger have other arrhythmias or other triggers that cause their AFib. As we get older, the back chambers of the heart called the atrium are sort of a wear and tear item in our hearts. And as they age, sometimes this is why we see an increase in AFib as we go into our elder years. It doesn't necessarily mean that it's not treatable in those elder years. In fact, oftentimes patients who are older have a little more more difficulty with tolerating medication alone, and that's why the ablation strategies still become much more common even in our 70, 80, and sometimes 90-year-old patients.
Okay. All right. Thank you. Okay. Before we dive into the next question, just a quick reminder for the audience. Feel free to submit any of your questions that are popping up now for you in the chat, and we will answer them after we get through the submitted questions. Okay. So next question here, Dr. Stabenow, we will go back to you. Is cardioversion recommended for non-symptomatic AFib? Oh, I think you might be on mute. There you go.
So that's a really good question. Because especially after AFib has been present for some time, sometimes the symptoms are not so obvious. And that's because, I've had patients tell me, oh, I can't move around like I used to anymore. And I just thought that that was part of getting older. And then, we do the cardioversion, which, as you know, doesn't cure or prevent AFib. It just kind of reboots the computer, if you will, sets you back into the normal rhythm for a while. They said, wow, that really made a difference to me, and I felt great. So if you're, especially if you've had AFib for some time or you're unsure if you're symptomatic, then a cardioversion can really help clear that up.
Okay, very helpful. Thank you. All right, Dr. Gus, we will go back to you. What are the chances AFib could reoccur after a seemingly successful ablation? And what do you recommend if an ablation is not successful for AFib?
Well, sometimes patience is part of it as well. When a patient has an ablation, oftentimes we talk about a 4 to 6 week period afterwards, where it's not uncommon to either have extra feelings of palpitations or extra heart rate, sometimes even extra events that include some atrial fibrillation. And that doesn't mean necessarily that the ablation hasn't been successful. The procedure does take some time to heal in. There are options that to still use medications after an ablation. In fact, there are certain medications specifically for control of rhythm or antiarrhythmic drugs that may be useful even if you've had an ablation. If it's not successful, this normally means in the long run that either there's still a reduction in how much AFib or symptoms they have. And if that's not achieved, then sometimes it's time to come back as a team and discuss what other options, including for some patients, more permanent rhythm control or rate control with, like we spoke about earlier, like a pacemaker or other options.
Okay, thank you. Dr. Stabenow, question for you. Why should someone get surgery when AFib is inconsistent?
So I think, this gets back to the point that, the procedures for AFib are primarily procedures for control of symptoms. And so, if AFib comes and goes, it's called paroxysmal atrial fibrillation. but it can still be incredibly bothersome. And if it is, you know, you can tolerate it. That's certainly an option. And we can try some medicines to reduce those symptoms. But if you'd like to try to get rid of those symptoms, the procedure is there to help.
Okay. All right. Okay, Dr. Gus, going back to you, perhaps we can discuss a little bit about evolution in the field. So, how has ablation improved in the last 10 years? Can one still have an ablation procedure if they not only have a pacemaker, but also a watchman?
That's a very good question. Ablation has really come a long ways in the last 10 years. Miniaturization, as well as more better and faster computers, has made it much better and more precise. One of the things specifically that's happened is procedure times have dropped significantly. Procedures 10 years ago were often as long as 4 or 6 hours, and oftentimes can now be completed in 90 minutes to almost 2 hours at some times. Additionally, our systems have gotten precise enough that we can often do this in some cases without even using fluoroscopy, which is a form of X-ray. And for patients that already have a pacemaker or a watchman, it's no longer an exclusion. It's not something that would prevent you from having an ablation. For patients who have a watchman who've been able to successfully get off blood thinners in the long term, sometimes they may still need to use a medication or a blood thinner by mouth over the next 4 to 6 weeks in some cases, as that allows the ablation to heal in, as the area ablated is not behind the watchman and not covered by the watchman. But neither a pacemaker or a watchman actually prevents having AFib. And many patients who have had a pacemaker when they're younger often go on at some point to develop AFib, and oftentimes do need an ablation to help treat them.
Okay, great. Thank you. All right, Dr. Sabinow, question for you here, a little bit more specific. After ablation, how long should someone wait to get off blood thinners?
So great question. So if you remember, you know, the treatment of AFib can be divided up into stroke prevention and treatment of symptoms. Blood thinners are there to prevent the risk of stroke. Ablation is there primarily to treat the symptoms. So while it is possible, and it definitely doesn't happen in all cases, that, you know, someone is otherwise at low risk, has no atrial fibrillation at all after the procedure, we could have an individualized discussion about whether, you know, stopping the blood thinner might make sense for that person. But in general, the blood thinner continues after AFib ablation. Now, if there is an issue with the blood thinner, bleeding or some other problem with it, including financial, then a watchman procedure is there to help with that, which is a procedure where the appendage of the left atrium, which is the place where the blood clots often form in atrial fibrillation, is occluded with a small plug. And that procedure can be done in order to get a patient off of blood thinners and still have protection from stroke with atrial fibrillation. These days, actually, those procedures can be done at the same time. The ablation and the watchman can be done together.
Okay. All right. Thank you. And I see a lot of questions coming in the chat, so we will turn to those in just a minute. But for now, we will wrap up our submitted questions here with a few more. So Dr. Gus, going back to you, what happens with end of life decisions when someone has a pacemaker?
It's a very important question. Patients often come to us and ask us, is this going to keep me alive if I've made a decision that I've chosen more of a palliative route or hospice? And as a general rule, pacemakers do not prolong life in a way that is considered essential. And the normal bodily functions, if they do, as people proceed towards end of life, as things like kidneys, livers, and electrolytes change, oftentimes a pacemaker is not in and of itself going to prolong someone's life unnecessarily. When someone has a pacemaker defibrillator, a device that can deliver an electric shock to prevent dangerous heart rhythms, oftentimes in these situations, we disable the function of the defibrillation, and the pacemaker function is actually left on and allowed to continue.
Okay. Great, thank you. All right, Dr. Stabenow, question for you. What happens if something goes wrong with a pacemaker or leads?
That's a great question. And, as pacemakers and leads, like everything made by humans, are fallible. And, their lifespan may be 20, 30 years. But eventually, leads break down over time because you can imagine as the heart beats and they're constantly flexing, there's mechanical stress on them. When a lead mechanically fails or breaks, we have a choice. We can take it out and replace it, or we can just add a new one. And that's all, the taking it out versus just adding a new one is an individualized discussion with the patient about the risks and benefits. If, however, a pacemaker or a defibrillator lead should become infected, then it has to come out. And unless the patient is too sick to undergo procedures in general, that's when we make a strong recommendation based on the guidelines that we need to take these out. Now, the procedure to take out pacemaker defibrillator leads is a safe procedure. It does have some rare risks associated with it, which are, while rare, can be serious. So it's important to have a thorough discussion before these kinds of procedures with the patient and the family to make sure that everyone understands.
Okay, absolutely. All right, thank you. Okay, Dr. Gus, how long should someone in AFib wait before going to the ER if there are no other symptoms?
That's also a very good and important question. One of the things to consider is that if you don't have a significant history of AFib, or you're unprotected from the complications of stroke, either by a blood thinner or a previous Watchman implant, it's important to reach out to your doctors. And if you're not having any other symptoms, oftentimes you don't have to go and wait in an emergency room. If it's just because with your history of AFib and you're having an episode of AFib without other symptoms. If symptoms start to include feeling palpitations, heart racing, or include things like shortness of breath, or if the episode lasts more than a few hours and it becomes uncomfortable, then someone should seek emergent medical attention. And oftentimes, medications can be administered in an emergency room to help either stop an episode of AFib or slow it down so that it can reset itself even without other procedural intervention.
All right. Okay, last question here before we go to our live questions from the audience. Dr. Stabenow, how can someone reduce episodes of AFib? Can you maybe discuss lifestyle changes or choices, perhaps such as exercise, a healthy diet, along those lines?
I mean, absolutely. Exercise and healthy diet, yes, will improve your health overall. So the factors that we know contribute to atrial fibrillation include, in some patients, alcohol consumption can be a potent trigger for episodes of atrial fibrillation. Excess body weight, weight loss is one of the most challenging things, but if it's able to be accomplished, can often help reduce the episodes of atrial fibrillation. If somebody has obstructive sleep apnea, then treatment of this can be helpful with things like CPAP. In terms of diet, probably the diet that has the most evidence behind it is something called the DASH diet, which focuses on foods lower in sodium. And that also helps control the blood pressure, since we know that reductions in better control of blood pressure is also likely helpful in atrial fibrillation.
Okay. All right. Helpful advice there. Thank you. With that, let's turn to the live questions. And how this will work, I will read out a question, and whoever wants to chime in, feel free. This is definitely a discussion. So by no means do we have to take turns here. So for the first question from the audience, can the physicians explain the pros and cons of ablation versus the Watchman procedure? I know you chatted about that a bit, but if you could dive in here a little bit more, this person is interested for your opinions.
I think it's a great question. So when we talk about ablation versus Watchman, well, like Dr. Stabenow said, a Watchman is designed primarily to replace the need for blood thinners and prevent the risks for stroke. It's a procedure. It is minimally invasive. It's done through an IV through the groin. It requires sedation at the time of the implant. It takes often between 1 hour and an hour and a half, and has a relatively quick recovery time. What often happens then is that about 45 days down the road, a repeat set of images are completed to make sure that the device has healed well and sealed up. And then from there, a patient is only on baby aspirin, often lifelong at that point, instead of being on an actual blood thinner. When we talk about ablation and pros and cons, again, the primary question here is more in terms of uh, the benefit or the trade between the use of antiarrhythmic drugs or medication that's taken daily, sometimes several times a day, versus a procedure where up front the risk is being taken in order to reduce the long-term effects of AFib. Several medical studies have shown that the earlier that ablations are completed, the more successful they are in the long term. And that allows patients to save a cumulative reduction in medication that they take over the course of their years. So oftentimes we talk about ablation, it is about reducing drug therapy, about being on less medication on a day-to-day basis. And for a Watchman, it's more in that vein of trying to reduce the need for or eliminate the need for blood thinners.
Well said.
Perfect. All right. Next question here. I know we talked a little bit about age, but this person is wondering, is there an upper and lower age limit for a patient to receive a pacemaker?
No, is the answer. The pediatric doctors sometimes have to put pacemakers in very young children. And, you know, generally speaking, the wear and tear on the electrical system of the heart accumulates only as we get older. And so young people tend not to need pacemakers. And so, um, yeah, put a
Okay.
pacemaker in when it's needed, we'll put it in.
Perfect.
And I think, in follow-up to that, I think an important thing is true. There is, as people get older, oftentimes we have to plan in advance for replacement of a pacemaker battery. These devices often last between 10 and 13 years at this point. The technology always is improving. Each generation that's come out has been a little better and lasted a little bit longer. But certainly we replace batteries in folks even in their 90s and even into their triple digits.
All right. That's great to hear. Thank you. All right. Does a pacemaker ever need to be removed or repaired? So kind of along those lines. And if so, what's involved and how does that require any special training or tools?
Yeah, so that's a great question. The most important reason for a pacemaker or defibrillator needing to be removed is infection, because we know that certain bacteria, when they enter the bloodstream, they are able to form what's called a biofilm or a sticky coating on the wires that go into the heart. And the properties of this coating are such that the IV antibiotics don't get in and aren't able to cure the infection. So we know that patients whose infected hardware is removed survive on average better, have a better chance of surviving their infection than patients where it's left in. Special training and tools are needed to take these devices out. There are mechanical and laser-powered cutting sheaths that are used to remove the leads from the body after they have been in for a long time, when the body grows scar tissue around the leads. When I do these procedures, I do them in what's called a hybrid operating room with a cardiac surgeon available in case there should be a complication requiring emergency surgery. Again, these are safe procedures and the complications are rare, but we do need to be prepared if they should happen.
All right, thank you. Okay, next question here. This person is wondering, can the doctors talk about what defibrillation treatment is, and can you talk about any recent updates in this treatment?
Sure, absolutely. Defibrillation is similar to cardioversion in that it's the application of energy in order to reset or restart cardiac tissue. It's sort of, as Dr. Stabenow said, sort of like rebooting the computer when there's a problem. When we do cardioversions, our goal is to restart the upper chambers of the heart. But when we're talking about defibrillation, it's because the lower chambers have gone into an irregular rhythm that is dangerous to the patient. For lack of a better description, it's the old school movie paddles, but all sort of miniaturized into a small device underneath the skin. In the last 10 years, the biggest updates have really been in terms of that devices have gotten smaller and more comfortable in the implant size and shape under the skin. The longevity of devices has increased without overly increasing the size of the devices. And there are now programming modes built into our pacemaker defibrillators that can prevent a shock or delivery of energy to a patient through pacing maneuvers that can break or stop a bad episode from happening without actually having to deliver the energy to shock the patient.
All right. Thank you so much. All right, moving along. What impact does a pacemaker have on a pregnant patient who is undergoing labor and delivery? Can the pacemaker malfunction or undergo changes during delivery and labor? Interesting question.
It's a good question indeed. It's very unlikely to have an issue with your pacemaker during labor and delivery. The devices are really self-contained, and in rare circumstances, if a patient has a defibrillator, we may ask that the device is reprogrammed into a different mode in order to adjust the sort of tracking ranges, as oftentimes heart rates are very elevated during the delivery of a child.
Okay.
If a cesarean section were planned, and the patient had a defibrillator, then we would reprogram it to ignore the cautery, the electrocautery, as we would for any other surgery.
Got it. Thank you. Okay. This next question maybe goes into our previous discussion, but is it possible to stop AFib without a pacemaker or ablation? Dr. Stabenow, I know you kind of mentioned lifestyle, but if you could expand on that, that would be great.
So, I mean, I have seen patients who commit, to a weight loss program and are able to lose a significant amount of weight. I have seen AFib stop on its own because of that. Weight loss is one of the hardest things to do in the whole world. It really is. And so, but it's not impossible.
Thank you. All right, next question here. Can the doctors talk about the differences between AFib and atrial flutter? What about heart block and AFib or flutter? And then one last follow-up. Can the doctors also explain what heart block is? So a few questions for you there, whoever wants to tackle it.
Sure, absolutely. I'll start with the first one there. A big favorite of mine. The atrial fibrillation and atrial flutter are both irregular, faster heart rates coming from the upper chambers. But it's best to think of atrial flutter as sort of the more organized cousin of atrial fibrillation. They both carry similar risks of higher heart rates as well as increased risk for stroke or transient ischemic attacks. And while atrial fibrillation is treated primarily in the left back chamber of the heart, oftentimes what we call typical atrial flutter, or the more common variant, comes from the other side of the coin on the right back chamber of the heart. When we talk about treating AFib, we're trying to prevent symptoms and reduce recurrence over a long period of time. And oftentimes for patients who have had an ablation for atrial flutter, sometimes we do get to use the word for curative treatment when we talk about certain kinds of atrial flutter, that once they've been ablated, after an adequate period of time for healing, it's very unlikely that they could recur.
Okay, great. Thank you. And Dr. Stabenow, anything you'd like to add to that question? I know there was a few.
I think one part of the question also mentioned heart block. Is that
Yes.
right? So what we say when we talk about heart block, it's there's upper and lower pumping chambers of the heart, which are called the atria and the ventricles. And when the signals, the normal natural pacemaker of the heart is located in the atrium. And when those signals normally the atrium pumps to sort of prime the main pump, which is the ventricle, and then the ventricle pumps. When the electrical signals from the atrium don't make it down to the ventricle anymore, the heart has a backup natural pacemaker that can take over, but then the upper and lower pumping chambers aren't working together anymore, and the heart can go very slow, and patients can feel pretty sick. And so that is what is meant by heart block, that condition.
Okay, thank you. All right, moving along, next question here. This is a little bit more of a specific question. This person says, I have PVC. Is it possible that could lead to AFib? Also, can a dilated left atrium lead to AFib?
So very, very good questions as well. PVCs are extra heartbeats that come from the lower chambers of the heart. And while extra heartbeats can trigger other heart rhythms or set off other heart rhythms, it has to be sort of looked at in a case-by-case basis. When we talk about the other question you had mentioned, it was in regards to dilated left atrium. Dilation or stretching of the left atrium, this back chamber of the heart, is one of the predominant factors that we do look at in trying to judge how long someone has at AFib and also how successful will be in completing an ablation and them being symptom-free. The more dilated, the more stretched out that back chamber is, the more scar tissue or fibrosis is present in that tissue, and the more disrupted the electrical part of that tissue is. So certainly, the more dilated a back chamber of a heart gets, the more difficult it sometimes is in order to get back to a more normal rhythm. And for patients with severely dilated left atriums, this is oftentimes where either an ablation and sometimes drug therapy is still needed, or those patients, sometimes it's more in line to consider a pacemaker option.
Okay, great. All right, next question here. This person is wondering, can the doctors talk about the effectiveness of ticasun, also called dalfatalide, and apologies if I mispronounced that. Is it effective at treating AFib?
Yeah, so dofetilide or ticasun is a medicine that acts on the certain ion channels, the potassium channels in the heart, which are part of the heart's electrical system. It can be helpful in reducing the amount of atrial fibrillation you have. It doesn't cure AFib. And in some patients, it can keep it away entirely. Dofetilide is, generally speaking, a pretty well-tolerated medication. But if folks have problems with, their kidneys, or as they get older, it can be unsafe. And it also has to be started in the hospital. It cannot be started at home as an outpatient. So there are pros and cons to this medicine. It also has to be taken twice a day. So that's a disadvantage.
Okay. Helpful call outs there. Thank you. All right. We have a few more live questions. Thank you all for submitting such great questions. This next one is talking a little bit more about lifestyle. So this person mentions, I'm sorry, let me bring this up. I'm losing my spot here with all these questions coming in. Okay. The doctors talked about triggers for AFib. Can they discuss the impact of sleep on AFib? This person says, I use a CPAP and have sleep apnea. I had normal sinus rhythm before I started using CPAP. Any thoughts?
Oh, that's a good question. So one of the long-term risks for developing AFib is certainly a correlation with obstructive sleep apnea. When you have obstructive sleep apnea, when you sleep at times, you're effectively speaking, you're not exchanging gas as well. You're not breathing in and out well. And sometimes this is seen with people who snore heavily or in people who startle themselves awake sometimes at night. This process is dangerous in itself because it puts a lot of extra work on the heart when it should be resting while you sleep. And it sort of, in a sense, prevents the heart from keeping itself, getting these opportunities to rest, like when we're sleeping and things like that. Obstructive sleep apnea has over time been seen as an increasing risk for dilation of the left atrium, for putting extra pressure on the heart and extra workload on the heart. So patients with obstructive sleep apnea, unfortunately, are at a higher risk for AFib and specifically also for atrial flutter. Treatment of obstructive sleep apnea, though, has been shown, along with weight loss, to reduce your risk for AFib in the long term, as well as to reduce the long-term progression or slow the long-term progression of atrial fibrillation. So it's important to manage obstructive sleep apnea. Some people, on the other hand, have very individualized triggers. Certainly, there are patients who have reported that ice, cold liquids, things like that have been triggers for them in the past, as the esophagus passes very close to the back of the heart and sometimes triggers events. Some people have spicy food and other things like that. But as a general rule, when we talk about lifestyle modification, we don't ask people to try and strip their diet to something that's not normal for them. Although if they find a specific trigger, we ask them to avoid it. More importantly, we ask patients to work on their weight, manage their blood pressure, avoid excess alcohol, treat things like sleep apnea.
Okay, all right, thank you. Okay, next question here, moving right along. This person says, I had a PFO closure 10 years ago. Would my condition mean that I would need a pacemaker instead of ablation?
So not necessarily. While the PFO closure device can make the ablation procedure more challenging because you may have to find a way around it to get over to the left side of the heart where we do the ablation. In many cases, it's still possible to do the procedure.
Okay. Next question here. Can the doctors talk about what is involved in the procedure to implant a pacemaker? Particularly what restrictions might someone face after the implant?
When someone goes to one of our sterile operating rooms to get a pacemaker, oftentimes they're placed under twilight anesthesia or light anesthesia. They're asleep during the entire procedure. The area often on their left or right shoulder near the collarbone is prepped, draped, and sterilized. And oftentimes over the course of approximately a 30 to 60-minute procedure, a small incision about 3/4 of an inch to an inch is made in the skin near the collarbone. An area under the skin is made into a pocket for the pacemaker device itself. And we use a vein that's accessible in the shoulder area in order to sneak several wires down all the way around the shoulders, back all the way back into the back door of the heart and into the inside of the heart. The pacemaker wires themselves have several different methods by which they can be attached to the inside of the heart. And when a good location is found, the leads themselves or wires are delivered to those positions. Afterwards, the leads are sutured or stitched to the muscular layer in the shoulder, which prevents them from moving or slipping. And after being hooked up to the pacemaker and being tested and everything's looking good, the skin itself is closed with several absorbable stitches. This means that patients don't have any stitches or sutures that have to be removed in the future. Everything is absorbed on the inside. Afterwards, they go back out to a recovery room. Oftentimes, they spend an hour or two until the anesthesiology team is happy that they're awake, that they're eating, that they're not nauseous, that they're feeling well. And after the device is checked, some patients are able to go home the same day, or other times go back to a patient room in order to rest and recover. And most of the time, in those cases, they're going home the next day.
Okay. Very promising. Thank you. All right. Are short episodes of AFib still related to strokes? How concerned should I be with the occasional flutter in my chest?
So the guidelines say that if you have episodes of AFib that are longer than 5 minutes, then these are episodes that would warrant blood thinning medicine in order to reduce the risk of stroke. We also know that the longer and more AFib that you have is associated with higher risk. The occasional flutter in the chest, if it concerns you, then it can be checked out with either something called a Holter monitor, which your doctor can put on, or there are devices like an Apple Watch or a Cardia mobile device, which can obtain an electrical recording of the heart function that you can show to your doctor. Those are helpful if you're having the symptom while you record it.
Okay. Thank you. All right. Next question here. This person says, I recently received a diagnosis. Can the doctors explain the differences between blockages? What is a second degree Mobitz type 1 and 2? Would these require me to need a cardiac device?
So there's several different ways in which the top chambers of the heart can end up either delayed or failing to send a signal to the lower chambers in the heart. Without being overly specific, when beats are missed without a warning, that's dangerous. However, when there's a delay that slowly prevents the occasional beat from reaching the bottom chambers of the heart, sometimes either medications can be at fault, or sometimes this is natural if this is asymptomatic to certain patients. So as a general rule, this second type of Mobitz, where there's sort of intermittent or random blocks of extra heartbeats without a warning, is dangerous and often leads to someone needing a pacemaker so that it doesn't progress to something called complete heart block, in which case the top and bottom chambers totally stop talking to each other. And in those cases, patients' heart rates are often very low and they feel ill and tired.
All right, thank you. Next question here. What treatment options are available if ablation or cardioversion didn't work?
So whenever I see a patient in consultation for atrial fibrillation, I do emphasize that sometimes people do need a redo or touch-up ablation procedure because sometimes the heart heals in ways that we don't expect, and so it is not that rare to need another ablation procedure. A cardioversion of course, doesn't do anything to control the atrial fibrillation. It's probably going to come back at some point. So the other thing to remember is even if the ablation does not totally eliminate the amount of atrial fibrillation, it can still reduce the amount you have. And especially if you have symptoms in AFib, that can be a real win.
Okay.
As Dr. Gus mentioned also, there are medicines that can be taken in conjunction, called antiarrhythmic drugs, in conjunction with the atrial fibrillation ablation procedure in order to reduce the amount of AFib that we're having or even keep it away entirely.
Okay. All right. Going back to the procedure process for a minute, this person is wondering, is there a recommendation or reason for implanting a device under the skin versus under the muscle?
It's a good question. It's often more depends on a patient's body shape and size. We often are able to use an area that is a little fat pad or space underneath the skin on the shoulder, and that's more than adequate for most patients. Sometimes, however, patients are extremely thin, and that could be uncomfortable or more revealing than they're looking for, especially with larger devices like what are called cardiac resynchronization devices, and in some cases, defibrillators. In those cases, sometimes we elect to put the device actually under the muscle itself. It's more aesthetically pleasing. However, it is a slightly longer recovery for some patients, as that requires making a smaller incision actually at the level of the muscle or around the muscle in order to get the device into that pocket. It does also mean that when you have a battery replacement down the road, that device has to be again removed from back from under the muscle. And sometimes over a long period of time, this has been shown to increase the risk slightly for damage to pacemaker leads. And so in most cases, we elect to put devices under the skin if it's going to heal well and be aesthetically pleasing.
Okay. All right. Okay, we have one final live question that I will ask, and then I have a final question that I will ask both of you to wrap up the evening. So for this final question, looking ahead into the future, this person is interested in what improvements to these devices do you both anticipate seeing in the next 5 or even 10 years?
That's a great question. I think that what are called leadless pacemakers, which are the devices that are sort of the shape and size of a bullet about and sit entirely inside the heart, are going to become more and more versatile and practical as time goes on. Those have the advantage that, there's nothing to implant under the skin of the chest, and the risk of infection is lower for those devices. Right now, most of them have some important limitations in terms of the functions that they can perform, which make them unsuitable for many people. But I expect as time goes on, they'll get better and better, and eventually we'll be doing mostly leadless pacing.
All right. Certainly exciting. Dr. Gus, anything you'd like to add?
I think the other thing we're seeing coming down the pipeline is that it's becoming more and more possible to place pacemaker leads precisely. And as we do that, we're getting better at putting pacemaker leads in a way that accesses the patient's own internal conduction system or wiring. And then when we're able to use a patient's internal wiring, in addition to what we're providing and helping out with, sometimes we're able to get a more normal result for the heart and something that the heart actually really likes and is able to improve the squeeze of the heart in patients with sicker hearts. So we're heading in a direction where we're able to use smaller and smaller devices that are lasting longer and longer. And we're getting to a more physiologic or natural version of pacing as opposed to where we were 15 or 20 years ago.
Okay, well, certainly exciting. All right. Well, as we wrap up tonight, I did have one final question for the both of you, and that is, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? So, Dr. Stabenow, I will go ahead and start with you.
So the main things I'd like people to sort of take away is that, to understand that the treatment of atrial fibrillation is split into the risk reduction of stroke and the treatment of the symptoms of atrial fibrillation. And there are different procedures and medications that target both of those things. For the stroke risk reduction, the blood thinner, or if needed, the Watchman procedure. For the reduction in symptoms and the burden of atrial fibrillation, the ablation and medications as needed. Also that I'd like people to take away that these procedures are safe, and that we have a lot of experts like Dr. Gus and myself who are happy to do these and help. Also, in terms of the pacemaker and defibrillator extraction procedures, those can be scary things to think about and talk about for patients. So it's important to find a specialist who does a good volume of these procedures at an experienced center and whom you can build a good relationship with and trust.
Absolutely. Okay, thank you. And Dr. Gus.
I think Dr. Stabenow said something really important there. And in taking care of patients and their health, it's important that patients are getting some of the best care they can get in the long term. And as we move into an era where we're able to get away from just using medication, it's become more and more possible with these procedures to get patients on less daily medication, especially off of medications that sometimes require taking them 2 or 3 times a day. Oftentimes, we're now heading in with patients to treat them in a way where they, instead of have to worry that they're going to be on more medication in the long term, that's something they get to look forward to. And finally, patients who have had AFib for even a short period of time often get very comfortable with it and become unaware that they're having symptoms. I hear very frequently from patients that they think they're just getting older. And just because people are moving into their 70s and 80s more and able to live with AFib, it doesn't necessarily mean that some of this is normal age and that fatigue and tiredness is normal to them. When we get them back to a normal rhythm, they're some of the first people to say, I'm feeling better, I'm on less medication, and more importantly, I'm sleeping better and have more energy to do things during the day. So I think this has become an important milestone over the last couple of years, that patients are finally heading in a direction where they're feeling more themselves as they get treatment.
Absolutely. A really important takeaway. So thank you. All right. Well, thank you so much, Dr. Stabenow and Dr. Gus, for your time this evening. Such great information was shared. I know I learned a ton, and that's because of you all for attending and submitting such great questions. So thank you. We will be posting an event survey so you can let us know your thoughts. Any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. You can also visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars like this one and more. Please also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, and innovation. You can also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics ranging from back pain to robotic surgery to hearing loss, men's and women's health topics, and much more. A recording of this event will also be sent to you so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.